mode.
Welcome to today's webinar, which is co-sponsored by Biodefense Network and the Public Health Foundation, titled How Local Public Health is Tackling the Opioid Crisis. We have an excellent complement of speakers today, and based on the number of participants, more than 500 people have signed up. This is something many people are interested in. My name is Dave Reddick. I'm Chief Strategy Officer and co-founder of Biodefense Network, the nation's leading public health preparedness consultancy, working at the intersection of public health preparedness and emergency planning and management. Before we start, I want to cover a few housekeeping items. If you have a question, submit it in the question box to the right-hand side of your screen. Vanessa Lammers of the Public Health Foundation is helping us today, and she may answer a question specific to you, or we'll have the questions answered later. Today's webinar is being recorded and will be archived for future access by the Public Health Foundation. If you experience technical issues today, close your browser and log back in. We have 4 speakers today, and we expect to conclude the presentations within the hour we have reserved. However, we welcome questions, and our panelists will remain on the line after the presentation, so we can fully expect to go beyond 1 hour. Stay with us if you can. Our topic today is the opioid crisis, and it seems that we hear more and more discouraging news lately. Just last week, the Pennsylvania Department of Health warned that a drug named carfentanil, which is causing an overwhelming number of overdoses there and perhaps elsewhere. The health department said the drug is a synthetic opioid with a clinical potency 10,000 times greater than morphine or pure heroin, and it can be absorbed into the skin, making it especially dangerous for first responders. An average of 80 Americans daily die from opioid abuse. It is indeed a crisis. That's why we assemble our speakers. Our first presenter is Jack Moran. Jack is Senior Quality Advisor to the Public Health Foundation and an adjunct professor of the Arizona State University College for Health Solutions School for the Science of Healthcare Delivery. He has more than 30 years of quality improvement expertise in developing quality improvement tools and training programs, implementing and evaluating quality improvement programs, and writing books and articles on quality improvement methods. Jack, welcome.
Thank you. Well, this is a topic that's near to my heart. Before I moved a few weeks ago, I was president of the York County, Maine, Choose to Be a Healthy Partnership on Public Health. And we had an epidemic in Maine in that we were the second leading state for babies born addicted to prescription painkillers or opioids. So how bad is this epidemic? Well, as you can see, it's everywhere in the country. It isn't localized. It's predicted that there's 1.9 million addicted to this painkiller and nearly 200,000 overdose deaths a year. So it's quite a bit as we go forward. And one of the things you find is that from where we are at the Public Health Foundation, we have tried to approach this from a tool we use called the Population Health Driver Diagram. And as we've been out at various conferences, we try to improve the public health by strengthening the quality and performance of practice. So we've been using this as a way to do that. And for some reason, there we go. Whoops. Too much. So this is the, go back. So using this population health driver diagram, we started this at the Practical Playbook Conference the Moran Foundation puts on last May. And we started talking to individuals about how can we use a tool to really help bring coalitions together in the community to help combat the heroin crisis. And what you find with the driver diagram, which I'm going to talk a little bit about, is more community specific, and this is rather broad. But one of the things you develop are goals, and things here like, how do we adequately and safely treat pain? Rather than just constantly giving opioids or something like that. Before I came to the Public Health Foundation for many years, I was Senior Vice President of New Baptist Hospital in Boston, and we're an orthopedic hospital. And what we had was a pain clinic. And we very seldom would reduce the amount of medications to people, but we gave them a way to really deal with pain. It's normal and so forth, and you don't need an opioid every time you have a little inconvenience. So teaching people how to deal with pain is something else. And again, one of the things we want to do is reduce the deaths from overdose. And you can see in this case from the diagram is really when we developed this at the playbook with a group of about 40, 50 people, people talked about, the primary drivers are education. We got to do more with data, surveillance, and so forth, especially with the drug industry, monitor prescription practices and so forth, and really make sure people understand the appropriate use of prescribed drugs. And then how do we really stop doing the illegal availability of drugs in the process? So one of the things that you find as we move in the driver diagram, and I'll get this down straight yet, is that we really start with an outcome. And that's really what we wanted to do. In this case, really, we talked about combating the opioid and heroin crisis. So it's clear and concise. Primary drivers, those are the ones we talked about, education, use of data, and so forth. And then secondary drivers, we really get down into the weeds a little bit. And we start to think about what are the changes or interventions we can do and make things moving forward so we can get down to some projects that we can do in the process. So you just think about a driver diagram. It's really, the aim is up about 50,000 feet. Goals come down about 30,000 foot, 20,000 feet at the primary driver. And then we hit the 10,000 foot view where people now start to see, here's some action we can take. What are some things we can do? And then beyond the secondary drivers, this is where we would start to launch some projects. How do we do things such as registries and so forth? How do we make this happen? So beyond that is really the secondary drivers. We get to projects, and then we monitor and measure those to make sure that their goals are achieved in the process as we're going forward. This is one we did, was really our start in the process, was looking at the role of antibiotic stewardship. And one of the things, we did this with IHI, CDC, and PHF, and we worked with public health groups as well as hospitals to really see if we could reduce the amount of antibiotics being used. As everybody knows, this is a crisis that you read about all the time in the paper, that we have nothing on the shelf to combat the new, rapidly spreading types of diseases that are coming in and infecting people. So again, we did this with hospital and public health group. We did it with the state of Connecticut and long-term care facilities, and then the state of Maine, we did it with the use of the public health department, hospitals, and long-term care facilities. And again, the whole idea was to bring coalitions together that could begin to start to really appropriate push on it. And one simple thing that came out of this was in Independence, Missouri, where we did it with the health department, the major hospital there, was that people required, especially daycare facilities, that if a child had a cold, they had to come back with an antibiotic. And you had to have a prescription from the doctor you could show. Well, as you all know, you don't need an antibiotic for every cold. So the health department, working with the hospital, bribing the daycare providers as they do training for them, and really explain things. And here, doctors, ID pharmacists, public health officials, and they came up with a thing, it was sort of like snot, sneeze. You don't need an antibiotic. And out of that, they got policies changed. So there are ways to do it when you get down into the weeds in the process as you're going forward. Oops. So the thing you do with the driver diagram is you start small. We always talk about that. Come up with something you can do. Have a baseline, have metrics, have improvement goals, and have a timeline, something you get done in 3 months. But think for the big picture and then scale it up quickly, because what you want to do is get it out, try it. If it works, scale it up to other things. So we've done things where we've tried screening process for obesity in clinics, did it in 1 or 2, it worked, we scaled it up to other ones in the process going forward. The other thing is, problem with all of this, if it was easy, I always like this, would be done by now. It's a big problem, and we all have to work together to tackle it. So when we do the process improvement program with the driver diagram, we have like a 17-step process to go through with an organization. It starts with a lot of pre-work, identifying who's going to be involved, get the aim out, and then you can see as you go through this, I won't read them all. Really towards the end, as you start to analyze action areas, you got to get people willing to do it and lead it in the community. You got to have measurement. Does it work? Where's the baseline? Do some trial implementations, and then finalize the change package. And the big thing is you want to sustain the coalition. When we first started out, we didn't have step 17 in it, but lately we've been learning more and more about if you get it going, you get a good project going, how do you keep that coalition together? And that's the key thing we want people to work with. So again, this is really what we've been talking about. And it's one thing you might want to try in your community, develop some goals. And you find when you get to the community level, the goals are much more specific. You won't have things like improve prescribing practices. You say improve prescribing practices in so many doctors' offices. You know, how do you reduce accidental overdose? How many do you have in your community? What's a good goal to be focusing on? And then begin to look at what are the primary drivers that really impact your community. And I always tell people this is really place-based decision making. It's your place. You have to decide what you want to do in this case. Some things work, you know, globally, other things don't. So you really need to work on your culture and your community, what will work and how can you get things done. And then as you develop the secondary drivers, those will be the things that really get focused on things that you can do as a group to make things happen. And one of the things you can do is you can take a look at the community guide that CDC puts out. And they have a lot of good things that help you to think about, here's some evidence-based interventions that you can do. And we've been doing some programs with WellSpan and Integris, and they've been using the community guide as a way to, you know, further the action that can be done, but in an evidence-based way. And let me just skip that one. But one of the things we talked about is, you know, if you start this process and you begin your projects, people have hunches from local communities that work. They have theories, evidence-based theories. They have ideas. So we always talk about getting a small-scale test going, see if those work. Follow it up, maybe expand it to a couple of other clinics, then expand it all over the place. And then finally, the PDCA cycle comes up with a plan, you know, check, standardize the approach, and then implementation of the change. You can get some widespread things to be done that way. And again, you know, this is our heroin crisis we talked about. You know, this is a guide. It would suggest that if you can try it in your community, we'd love to hear some feedback. It gives you a start. And one thing we always find with people is, you know, once you see a draft of it, monitor it, see if it works in your community, or make some changes that people will be agreeable upon that works for them in your community, because it is place-based decision making. And one thing we always talk about population health driver diagrams is that they're a living document. You modify them as you go along, you test theories of improvement, you learn what drivers and interventions are more important than others, and which ones are achieving your desired results. And then as it evolves, one good thing about it is, on one page, it shows the learning that's happened in the organization and what we've uncovered about the initiative. And again, one of the things you want to do is that you need to really keep you focused on it, because it's very easy for projects to derail. You know, people leave, change jobs, and so forth. So that's really why you want to do that step 17 right at the beginning. How do we sustain this coalition? So if people do leave, people pick up the pace from what they were doing before they left. And again, we try to make sure that we get any unpredictable projects so we can test, retest theories. And again, I'd let everybody in the community have the opportunity to be involved. Everybody's ideas get considered, and then the change is, you know, one that everybody owns in this process. And a big part of the equation in this, and all of these things, whether it was the opioid crisis or the antibiotic stewardship, we have to look at what is the individual community members. We can do a lot of things, a lot of interventions, but if the community and the individuals don't step up to the plate, nothing will happen. So one of the things we've been working with in some of the conferences and some of the areas we've been going with is how do you get the individual to change? You know, people think about the force field thing, you know, there's a lot of prevention, education, all those things we can do in public health. We can do treatment in the healthcare system, but we run up against culture, habits, family, environment, motivation. What are some of the incentives we have to give the individual to make sure that they change their approach to things, whether it's with any type of chronic disease or an addiction? What are the appropriate incentives that will make it happen? And too often, you know, a lot of times people come up with the very soft incentives, but sometimes you're going to have to, at some point, come up with some very difficult incentives for people to do it. And these are things you have to look at your local level what can you do to get the individual to change? Because we can do a lot of things in public health and healthcare, but if the individual doesn't change, not much is going to happen. And Public Health Foundation, you can look at this slide. This is a number of things we offer. I would suggest you visit our website and you'll find some other driver diagrams. We've done on oral health and some other things, and you might find those very interesting. Thank you.
Jack, thanks very much for that level set and for setting the stage for the rest of this program. It's obviously clear that local health departments have a lot they can do, so we're very happy to be able to present to you with some news from several local health departments around the community. We have a tag team from the Pacific Northwest. Maria Wood is administrator of the King County Board of Health, which is the governing authority for public health, Seattle and King County, Washington. She manages local policy development and government relations in Seattle and the surrounding towns and cities. She began her career as a family therapist working in community mental health and spent 10 years managing the family planning program for public health. Maria holds a Master of Marriage and Family Therapy from Pacific Lutheran University. Jefferson Ketchel is the Environmental Health Director of the Snohomish Health District, just north of King County. He has 22 years of public health experience and holds a Master in Policy Studies from the University of Washington. He is former president of the Washington State Association of Local Public Health Officials and past chair of the Washington State Board of Registered Sanitarians. He is a graduate of Harvard University's National Preparedness Leadership Initiative Executive Education Program and CDC's Environmental Public Health Leadership Institute. Jeff and Maria, take it away about the way your two communities work together.
Thanks so much. Can you hear me okay?
Gotcha.
All right. Maria, you there?
I'm here.
Awesome. All right. So we're going to talk about today, we're going to open up with the relationship between opioids and medicine return, and then go into descriptions about how first King County passed its medicine return ordinance, and then Snohomish County followed King County's lead and recently passed one as well. Maria, anything you want to add before we jump into this?
No, really appreciate the opportunity to talk about our programs.
Awesome, thanks. So, look at that. Slides advance. So first of all, in Snohomish County, we're experiencing a large problem with opioids and heroin. Snohomish County is 10% of Washington State's population, but is experiencing 20% of the heroin deaths. And so in working with local law enforcement, we really identified this as a primary issue for public health and public safety in Snohomish County, and we're looking at ways for how we could address it together. We were finding that teens and other people were finding the availability of prescription drugs very easy to get. In fact, in interviewing people who use a local needle exchange, it turns out that 91% of them were first addicted to prescription drugs before they moved on to heroin. And so there is a strong relationship there between the painkillers moving on to heroin. In fact, there was a LA Times article in July about the city of Everett, which is the county seat in Snohomish County, and its focus of how black market OxyContin would make its way up from LA to Everett and really feed the problem here in Everett. And I encourage you to take a look. It's a very great in-depth article called How Black Market OxyContin Spurred a Town's Descent into Crime, Addiction, and Heartbreak, and that's in the LA Times from July. And so looking at the leadership on the national stage in addressing these problems, providing safe drug disposal is part of the National Drug Control Strategy. And so we find it as a very worthwhile and evidence-based way to approach this issue. Since I'm also the Environmental Health Director here, I'm also looking at the environmental issues, though this was definitely very secondary to our drug addiction problems. One thing that really supported passage of our ordinance was the fact that our solid waste agency here in Snohomish County had banned pharmaceuticals from being accepted into the solid waste stream. And so pharmaceutical industry's recommendation through their My Old Meds program was in direct conflict with Snohomish County law. And so talking about how much medicines are out there that are not being properly disposed of, my wife and I have 3 children, and every time she had a baby, the doctor would pack her with a nice big fat bottle of painkillers to take home. And my wife's not a big fan of painkillers, and she may take half of one, but have 29.5 pills left over. And I think the general thought around the country is, if, well, I didn't use all the painkillers now, I'm going to save them for when I really need them instead of disposing of them properly. And so we have a lot of unused painkillers and other medications sitting in medicine cabinets around Washington and the rest of the country, and not a simple, easy, convenient way of disposing them and making sure that people who may steal or experiment or borrow or use them improperly don't have access to them. So, Maria, you want to jump in here?
Sure, I'll take over. And as Jeff has indicated, here in Washington State, this issue's kind of gone full circle. In our state legislature, really taking more of an environmental protection approach. There were several attempts to enact a statewide product stewardship medicine take-back that ultimately did not pass. And it was folks in our local hazardous waste management community locally in King County who got the idea to attempt to do local legislation given the lack of ability to pass things at the state. The pharmaceutical industry really has been the main against this idea, and there was a very broad coalition that represented both environmental justice and environmental protection groups, as well as community youth substance prevention coalitions and other human services folks. And this was back in the 2009 through 2012 era, so it was before the opioid and heroin epidemic really had taken hold. But as this moved towards a local opportunity, we had someone who was on the local hazardous waste group and also sat on the King County Board of Health, who brought this to our attention in 2010. Our chair, Joe McDermott at the time, who's a King County Council member, was really interested in this issue and determined that really the best way for the Board of Health to be able to bring this forward was to focus mostly on the human health impact, because that's where the jurisdiction and the expertise of the Board of Health really squarely sits on the human health impact, but also continue to have some really great advocacy from folks from the environmental protection community. So King County kind of started us off after we watched Alameda County, California's Board of Supervisor pass something, and so we were the first of the counties who started to go here. So going to back up just a titch to tell you about King County, Washington. The Public Health Department is a county city health department. It is technically a department of King County government. It has responsibility for the health of all 2.1 million residents here. Our Board of Health is an amalgamated board of elected officials and health professionals. And in addition to doing a lot of really entrepreneurial policy making, they do provide the regulatory authority for the local health department to do our regulatory activities, including issuing permits, collecting fees, and then enforcing health protection activities. So the board, as they took on their work, moving forward here, sorry, advancing. It took us about a year to make this happen. We wanted to ensure that we were inclusive, people who were interested in this, again, with the one dissenting, primarily dissenting voice from the pharmaceutical industry. We had a subcommittee of our board do the policy thinking about this in terms of what they hoped a stewardship plan would in fact do, and really its goal was to reduce the availability of opioid medications and other medications for diversion. Opioid was kind of the backdrop, but certainly there are dangers of overdose and misuse from other categories of medications that are sitting around in people's medicine cabinets. We did do hearings that included the stakeholders. We invited panels of both pro and con folks, and then really dug into the policy decisions in drafting our rule and regulation. Ultimately, it was passed in June of 2013. And then we were promptly sued. So, which is what we expected. Following Alameda County experience, they were also had a fairly similar philosophy in their rule and regulation down there. Pharma just kind of changed the names in the lawsuit and aimed it at us, and so we continued to work kind of behind the scenes, hoping that we would have to be able to, we would prevail in the pharmaceutical lawsuit, and ultimately the Supreme Court deferred taking action on the appeal that was put forward by the pharmaceutical industry, and so the court decision against Alameda and ultimately Public Health Seal and King County and was dropped, which we really appreciated that happening in 2015. So we're on track now. We have a stewardship plan that has been approved, that we have pretty decent participation from the pharmaceutical industry. We have most of the very large wholesalers participating in underwriting the costs of the plan. It's been a little bit slower than we would have liked, but where the plan is doing a good job of getting participation from local law enforcement and pharmacy chains around our county, and we hope to be fully operational by the end of this year. Jeff, back to you.
Awesome, thanks, Maria. So Snohomish County is just north of King County, and we are a health district, which means we are an autonomous political entity, but the county still has ultimate responsible for what we do and how we do it. But our board is made up of 5 county council members and 10 city council representatives. So here we go. So for the past, since 2010, Snohomish County Health District, in partnership with the Sheriff's Office and local police departments, have operated a safe medicine return system located at police stations around the county. And since 2010, we've collected about 34,000 pounds of medicine. However, this is fully funded by local governments, and one of the philosophies of product stewardship is that the industry that generates a product ought to be responsible for that product's end of life. And neither the Sheriff's Office nor the Health District could continue afford to operate these systems, and we felt that we were just barely scratching the surface on the need of our community. And how the system operated was we'd have secure medicine drop boxes at the police departments, and then the health district staff or police staff would then collect that medicine and store it in the Sheriff's Office evidence room. And then twice a year, Sheriff's Office staff would transport that to appropriate incinerator or other hazardous waste facility. And they were often, these evidence rooms were getting so full of medicine, it was getting difficult for the Sheriff's Office to do their regular line of business. And so they expressed to us their interest in getting out of that line of work, much less being able to afford it, and we agreed. And so we began working with our Board of Health to really look at some other options. Again, lack the staff, lack the resources, lack the capacity to really do this well. And the fact that these were all located at police departments meant they probably weren't as convenient and as accessible to our customers as they needed to be. So we began a process this year, putting this together, and within the several months of work with our board and stakeholders, we were able to pass it in June, and we were the 8th jurisdiction in the country to do so. I know a couple more have since joined King County and Snohomish County in passing these, and I know many jurisdictions have tried and failed, such as LA County and in California, but I know more are have these programs in the works, including some others here in Washington. And so we are currently in the process of getting the stewardship organization up and running, and everything is planned to be up and running by sometimes the spring of next year. And meanwhile, we're continuing to look at operating the existing program so it has a smooth, seamless transition. And that is all.
Jeff and Maria, thank you very much. I think your presentation demonstrated that sometimes we may not be able to get the state officials to do what we want to do, but we recognize the value of doing something. So you've both taken it on the countywide approach, and you've both been successful. So congratulations. I'm sure you'll be happy to respond to any inquiries from listeners or participants in this webinar if they have particular questions. So thank you for the contact information here. And participants, feel free to reach out to Maria and Jeff. They're proud of what they've accomplished, and I'm sure they're going to be showing a good number of positive results. So I'm sure they'll be happy to chat with you about the particular burdens they had to overcome. Our final speaker is Deborah Buckner, has directed the Marion County, Indiana Health Department's Substance Use Outreach Services program for the past 7 years. She holds bachelor's and master's degrees in social work and is certified in alcohol and drug addiction, and is licensed as a clinical social worker and a clinical addiction counselor. She's here today to tell us about her work in Central Indiana. Deb, take it away.
Thank you, and thank you so much for this opportunity today. The local heroin epidemic is growing at an alarming rate here in Marion County. We've had overdose deaths during the 2011-2014 more than any other county in Indiana, accounting for 1 of every 5 that occurred. The rate of fatal drug overdoses in Marion County during 2014 was more than 7 times the rate in 2000, 23.9 deaths per 100,000 residents versus 3.3. And last year, there were 213 Marion County residents who died of a drug overdose. Most were Caucasians, 82%, and male, 62%, more than half involved in opioid. The Marion County Public Health Department and the Substance Use Outreach Services, which is a department of the Health Department, which comes under my directorship, we have prevention strategies that we've included that we provide within the community. And those include substance use case management services. I have a staff of case managers, to include case managers, and what they do is conduct intake assessments to determine a person's substance use disorder needs. And if that client is appropriate for substance use services, then the case manager can actually refer into care at Salvation Army Harbor Light Center. Once that person is referred and is accepted through Salvation Army Harbor Light, then we can actually fund his or her substance abuse treatment. We also provide, we do substance use disorder treatment resources, support services for families struggling with a loved one's addiction. Almost daily I have family members who call in to express their stories of how they are dealing with their loved one's addiction and where can they go for services, for resources, for treatment. So it's good to be able to say that I can provide some treatment, and I will not only provide the resource, but in a lot of the cases provide the funding for those family members. In addition to that, we have had quarterly lunch and learn presentations where we've provided presentations such as one topic was when addiction is close to home, and we invite family members, community members, as well as our health department staff to come in and to listen to the presentation, and we provide them with information, coping strategies, so that they can learn how to effectively deal with their loved one's addiction. Oftentimes, family members try to help, but they enable rather than help. So we give them the tools they need to do that in a healthier way for both themselves as well as their family members. And then we also distribute toolkits, which I'll talk a little bit about later, and also talk about the increased community-based naloxone distribution. Substance Use Outreach Services combats the opioid epidemic in Marion County by providing case management services. As I said earlier, our program, Substance Use Outreach Services, has entered into a contractual agreement with the Salvation Army Harbor Light Center to provide substance use disorder treatment and care services. And those services include detoxification and residential treatment. And our clients usually remain at Salvation Army for anywhere from 30 to 45 days on average. This program also includes transitional housing and intensive outpatient classes. And the Substance Use Outreach Services program, as well as Salvation Army Harbor Light staff, assist clients with employment and housing resources, which are the two priority needs of our clientele. We also provide, with our community-based social services agencies, provide pre-employment services, or they provide pre-employment services, transitional and pre-release services, job development and placement, treatment and addiction support services, care coordination and case management, housing assistance, HIV, STD, and hepatitis testing, and education. SUOS has also partnered with the Indianapolis Emergency Medical Services to obtain opioid overdose education and intranasal naloxone training for both my staff and the Health Education Promotion and Training staff, which is also a part of the Marion County Public Health Department, as well as the community-based care nursing staff. The local response has been strengthened by training others, which include SUOS, which is Substance Use Outreach Services, Health Education Promotion and Training, and the community-based care staff nursing. We will all train potential bystanders to administer naloxone when opioid overdose is suspected, in addition to taking other actions, which includes rescue breathing, calling 911. After that training has been done, each participant will be eligible to receive tools which include an overdose prevention kit, which includes a nasal atomization delivery device, substance use disorder resources, and referral information, and information about the services that we provide here at Substance Use Outreach Services program. The Indiana State Department of Health is working to expand participation in naloxone kit programs and distribution of the opiate rescue kits among local health departments for distribution throughout the community. These are some of the collaborative partners that we have in the community. We have over 50 that we are currently working with. And some of those include the Indianapolis Public Schools, which is the largest public school district here in Marion County, and of course Salvation Army Harbor Light, Wheeler Mission, which is a shelter for both men and women and families, Volunteers of America, Fairbanks Treatment Center, and the list goes on and on. And we also partner with such agencies as the Indiana Minority Health Coalition, Eskenazi Health Multicultural Affairs, Indianapolis Urban League, Drug-Free Marion County, and again, many more to add to that list. The Substance Use Outreach Services Program has successfully reduced opioid dependence in Marion County. During 2015, SUS funded substance abuse treatment services for 73 residents, and during 2016, and as of July, we have funded substance abuse treatment services for 58 residents, and we've identified 101 hepatitis C positive individuals. That's out of a total of 308 screenings that we have done so far this year. Again, thank you so much for allowing me to present today.
Deb, we're glad to have had you join us. We had a question about your Lunch and Learn series.
Yes.
How often do you hold those, and what sort of things do you talk about during them?
Thank you. We hold our Lunch and Learn series quarterly. So the first one was on when addiction is close to home, and we equipped participants with the tools that they need to deal with a loved one who's struggling with an addiction. We have done one on other drugs to include methamphetamine, and at each of our Lunch and Learn series, we provide the participants with a toolkit. So that's treatment resource information. There's support groups such as NAAA, where those meetings are held and their schedules, as well as information about our program. If you have a loved one, or if they're, and we often have people who call in and say, I need treatment, I need help, I'm addicted to heroin, and we are able to do an intake assessment and get those individuals into treatment. So, but we hold those Lunch and Learn presentations on a quarterly basis.
Thanks, Deb. So I have a question for Jeff and Maria. Both of your programs are about to get started. What kind of goals do you have in terms of pharmaceuticals that you expect to collect, and how will you know if it's been a success?
Maria, you want to launch?
Sure. Well, in King County, prior to the implementation of the Board of Health Rule and Regulation, we had a pretty broad coalition of actual collectors. So we had law enforcement collecting unused medications, and we had one of our large HMOs, Group Health Cooperative, also collecting medications, as well as a local pharmacy chain, Bartell Drugs. So we have some baseline information about what kind of collection effort we had with that kind of spotty availability of collection. So certainly we hope to do better than we did then, and one of the pieces of our legislation that we're really proud of is that the stewardship plan is responsible for providing at least one take-back location in every incorporated town or city, plus one additional site per every 30,000 population. So we know that when we get started, that we probably won't be at the peak number of locations that are potentially there, but we know that easy access for residents kind of in their day-to-day errand running and as they're out in the community is as many locations as possible can be out there. So we're really looking for the number of pounds of medications collected, as well as looking to see if we're watching really closely with researcher partners at the University of Washington, the opioid death and overdose statistics. Clearly this is only one strategy to prevent overdoses and misuse of drugs, but we'll be keeping an eye on that population-based data to see how we're doing. Jeff?
Sure.
You may have. Go right ahead, Jeff. Sorry.
Oh yeah, just quickly add that on the pounds issue, in Snohomish County, we're only collecting about 1/4 of what the British Columbia product stewardship system is collecting, and so I think that's a good sort of benchmark to compare ourselves to as well.
Thank you. So we had another question. You sort of covered this, Maria, but I want to be sure we answered it fully. Do you use drop boxes for collection of prescription medications? If so, what types of locations are they at? I think you started to answer that, sort of answered it, but if you wouldn't mind telling us where all people might find boxes in your community.
Sure. So this is entirely voluntary for the collectors. site. So there's no one entity is required to be a collector, but no potential eligible collector it can be turned away. So eligible collectors include law enforcement offices and retail pharmacies and hospital pharmacies. And then we also know that there's a significant issue with medications kind of getting clogged up in nursing homes and other kinds of facilities where folks who are ill or aging have medication that needs to be disposed of. So we've allowed there to be collaborative agreements between those kinds of facilities and pharmacies so that those medications can be easily disposed of by those facilities as well.
Thank you, Maria. Deb, we have a question for you about your Lunch and Learns. How many people attend these Lunch and Learns, and how do you advertise it? How do you get funding for it? And how do you get funding for it?
Okay. Our Lunch and Learns, we have anywhere from 30 to 40 people so far who have participated. Our funding comes from my budget, and we have also received some funding from the Ryan White program because we do like to offer some snacks during the presentation. And I'm not sure if I remember the third question.
I think that's it. How many people and how do you get funding? So you've answered that, but
and we distribute. We publicize by distributing flyers, and I have an outreach staff again who goes out to over 50 locations. So we spread the word that way, and we have a local newspaper that we Marion County Health Department newsletter that can go out as well. So we are able to put the word out pretty vastly.
Great. And then another question for you, Deb. Are the substance abuse programs activities overlapping with other outreach activities such as infectious disease, Hep C?
My staff also provides STD and HIV testing. So when we go out into the community, which includes schools and churches, community-based organizations, neighborhood associations, we provide free testing as well as assess people who may be in need of substance abuse services.
Great, thank you. And then you have another question for you, Deb. How are the programs contracted with the Salvation Army funded? Has the county's public health budget been increased, sustained, or cut in recent years? I think I probably know the answer to everybody's budget has been cut in recent years, but maybe you can answer.
The funding comes directly out of my budget. The director, the Marion County Public Health Department's director, Dr. Virginia Kane, has allowed me to haven't increased my budget, but I have taken funding from my budget to provide the funding for the treatment. She thinks it's as important as I do, that we start somewhere. And I'm continuing to look for additional funding through grants and in other forms.
We've met your director, and she's a very wise woman. So
yes,
she's doing a great job there. So this is a general question. I think anyone can answer it. In my area, we have brought together some stakeholders in our community to discuss our concerns with substance use and abuse. I am wondering where agencies are finding the money to make some interventions happen. Grants, state funds, local funds, any guidance would be helpful. Jeff or Maria or Jack or Deb?
Well, locally, we have what's called Recovery Works, which is part of the Department of Mental Health and Addiction Services. And those funds are designated for people who have either come from incarceration, either prisons or jails. So that would help in that area. It is still a challenge as far as finding funding to send people to treatment. So that's definitely a challenge that we still face here locally.
So Jack, Maria, Jeff, do you have anything to add to that?
In Snohomish County, we have a contract with our solid waste utility to help fund this work with the eventually goal of weaning ourselves from using that funding for this reason through the product stewardship system and charging permit fees to the stewardship organizations to be self-sustained.
When I was back in Maine, we got funding through the drug-free community.
Drug-free community. Okay, cool. Thanks, Jack. So there's a question as well about where can people gain access to the legislation, and I'll bet if they contact either Maria or Jeff, whose contact information is on now, you'll be happy to provide copies of that legislation, I'm presuming. Am I correct?
Sure thing, and we have a website in King County that has all kinds of stuff on it, so happy to provide that link.
Great.
As well as we do. So.
Great. So you can check the Snohomish or Seattle, King County websites, or contact Maria or Jeff directly on the addresses shown on your screen. Deb, you mentioned a toolkit.
Yes.
What's in that toolkit?
The toolkit contains information about treatment resources. So we specifically outline the names and locations of where treatment providers are, whether they accept insurance or if it's cash-based only. And we also provide resources and information about the Substance Use Outreach Services program, how they can receive funding from us to get into treatment, as well as information, schedules, locations of support group meetings for both families as well as the individual who's struggling with the addiction, such as NA, AA, and other resources like that.
Thanks, Deb. So Jeff, here's one for you. For Snohomish County, do you accept medications from island communities? So I guess this would be outside of your county.
Both King and Snohomish counties do have islands as part of our counties, and so yes, part of the requirement for the stewardship organizations is to provide a convenient, secure method for medicine return. So, yes.
Terrific. Okay. Thank you. Deb, I think we've all heard cases where people have said, I had no idea leave the blank here, my son, my nephew, my daughter had a problem. And I'm sure we've all heard those things. What sort of thing would you tell a local public health employee that they can tell their residents to be mindful of, to be looking out for, that might help them recognize a member of their family who is having a problem with opioid?
Oftentimes, if you observe their patterns of behavior, change in friends, so their social circles change. They are no longer socializing with the same friends, and so there's a shift in that. And as I said, the behaviors and their appearance, if it goes lacking, where they were very neat and clean, and then those changes, or if they start to get into, of course, into trouble with the legal system, and they make up excuses for everything except for the habit that they have. So those are some of the things, and oftentimes I've had family members to share how the one who's struggling has become belligerent, or they're almost afraid to have them in the home. So again, those are some of the things that's been shared with me, and in my years of experience, that's been some of the things that have changed during the course of a person when they start to experiment. And we've had a lot of younger people coming to our office who have now become addicted. In years past, never a lot of young people who became addicted, but that is not the case anymore. And in their situations, they have dropped out of school, they have started to live on the streets or can't take care of their young ones or their babies. Those who have children, parents, grandparents have had to step in. So it's just stories like that can give you a picture.
Thank you. One final question. Do any areas have a fentanyl patch return program?
We don't at this point.
That would definitely be included in our medicine return systems.
Ours as well.
Okay. Thank you all very much for participating, Jack and Maria and Jeff and Deb. We really appreciate this. I want to just close this by mentioning that we said earlier an average of 80 Americans die a day of opioid-related overdoses. Assuming that's correct, and we have no reason not to believe it, then it's fair to say that 3 people have died in the 1 hour that we've been conducting this webinar. This is clearly an issue that health departments around the country must take action for. And we've given you some examples of programs that health departments can begin to follow and activities by local health departments to deal with it. Our guests have very graciously provided their contact information, and I know they'll be happy to respond to any questions you might have. So thank you all very much. You will be getting a survey after this, and if you have any thoughts about other topics for webinars, we would welcome those thoughts. Thank you all very much, and have a terrific day.
Thank you.
Thanks.